To truly understand GBS, we have to look at how it presents in the wards. On your exams and in clinical practice, GBS shows up in two classic scenarios. Scenario A, the neonate. A 12-day-old male infant is rushed to the emergency department. The parents report a high fever, severe irritability, and poor feeding. On physical exam, you note a bulging fontanelle and marked neck stiffness. A lumbar puncture is performed immediately, revealing purulent cerebrospinal fluid. This is a textbook presentation of late-onset neonatal bacterial meningitis. Scenario B, the obstetric patient. Alternatively, consider a 26-year-old postpartum female. 24 hours following a prolonged vaginal delivery, she develops a high peripartum fever, severe lower abdominal tenderness, and foul-smelling vaginal discharge. This is a classic case of endometritis and puerperal sepsis. Keep these clinical pictures in mind, because every biochemical and morphological property we discuss next is what explains these exact pathologies. Cellular morphology. Morphology. What does GBS look like under the microscope? First and foremost, Streptococcus agalactiae is a gram-positive, oval-shaped coccus, measuring approximately 0.5 to 1 micrometer in diameter. Under oil immersion, you will see them arranged in pairs or short chains. Why chains? Because cell division in Streptococcus species occurs strictly in a single plane. When they divide, the daughter cells fail to fully separate, leaving them temporarily attached in these elegant microscopic bead-like structures. 3 critical structural features for your exams. First, GBS is non-motile. Second, GBS is non-sporing. Third, GBS is encapsulated. This capsule is heavily linked to its virulence, as we will see in a moment. So remember, gram-positive oval cocci in short chains. Culture. In the laboratory, GBS is a fastidious aerobe and facultative anaerobe. This means it has complex nutritional needs and absolutely will not grow on basic nutrient agar or selective media like McConkey agar. To grow GBS, we must inoculate it onto 5% sheep blood agar. After overnight incubation, it forms translucent, mucoid colonies that are approximately 2 millimeters in size. Take note, MDs, these colonies are noticeably larger than the pinpoint colonies formed by Streptococcus pyogenes, which are usually under 1 millimeter. Now look closely at the hemolysis. Each colony is surrounded by a narrow, clear zone of beta hemolysis, representing complete lysis of red blood cells. However, the zone of beta hemolysis in GBS is much narrower and less intense than the wide, dramatic zones of Streptococcus pyogenes. This subtle difference is a classic clue in practical exams. Definitive biochemical identification. This section is pure gold for medical board exams. How do we definitively identify Streptococcus agalactiae and differentiate it from other gram-positive cocci? First, GBS is catalase negative. If you drop hydrogen peroxide on a colony, there are no bubbles, which immediately rules out catalase-positive Staphylococci. Second, GBS is bacitracin resistant. If we place a bacitracin susceptibility disc on the plate, GBS grows right up to the edge of the disc. This easily differentiates GBS from bacitracin-sensitive Streptococcus pyogenes, also known as Group A Streptococcus. Third, and most importantly, the CAMP test is positive. GBS produces a diffusible extracellular protein called the CAMP factor, which is a phospholipase. When GBS is streaked perpendicular to a streak of Staphylococcus aureus on a blood agar plate, the CAMP factor acts synergistically with staphylococcal beta-lysine. This synergy results in a highly characteristic arrowhead-shaped zone of enhanced beta hemolysis at the junction, pointing directly toward the S. aureus line. If you see arrowhead-shaped hemolysis on a board exam, your answer is Streptococcus agalactiae. Point number 5. Virulence factors. Why is this pathogen so dangerous to neonates? GBS possesses an arsenal of virulence factors, but the absolute king is its capsular polysaccharide. This capsule forms a highly organized physical barrier that wraps around the bacterial cell. Its primary function? It prevents complement-mediated phagocytosis. Without opsonization, the host immune cells cannot recognize or engulf the bacterium, allowing GBS to survive and replicate freely in the bloodstream. Agalactiae is divided into 10 distinct capsular serotypes. Among these 10, you must memorize serotype 3. Serotype 3 is heavily implicated as the leading cause of late-onset neonatal meningitis. If a baby develops meningitis after the first week of life, serotype 3 is almost always the culprit. The disease spectrum. GBS causes a wide variety of clinical syndromes across different patient populations. Let's break them down. First, neonatal infections are divided into 2 distinct categories based on the age of onset. Early onset disease occurs within the first 0 to 6 days of life. This is vertically transmitted from the colonized maternal genital tract during or before birth. It is strongly associated with obstetric complications like prematurity and prolonged labor. Clinically, early onset disease most commonly presents as pneumonia and respiratory distress syndrome, alongside sepsis and bacteremia. Late onset disease occurs from 7 to 90 days of life. It is acquired horizontally from contact with a colonized mother, healthcare workers, or nursing personnel, and is not associated with obstetric complications. The most common manifestation here is meningitis, followed by bacteremia. Second, maternal infections. Associated with pregnancy, GBS leads to peripartum fever, endometritis, chorioamnionitis, and puerperal sepsis. Third, adult infections. GBS is not just a pediatric pathogen. It typically affects elderly patients or those with serious underlying comorbidities like diabetes mellitus or malignancy. In these patients, GBS causes cellulitis and soft tissue infections, especially infected diabetic skin ulcers, as well as urinary tract infections, UTIs, pneumonia, and endocarditis. Diagnosis. How do we confirm GBS in the clinic? For active invasive infections, culture isolation remains the gold standard. We culture the organism directly from sterile sites, such as blood and cerebrospinal fluid. On gram stain of CSF, you will see gram-positive cocci in short chains. For rapid diagnosis of neonatal meningitis, we can use rapid antigen detection via latex agglutination testing. This test can detect GBS capsular antigens directly from the CSF supernatant, giving us a rapid result before cultures grow. But the absolute most important diagnostic tool is preventive. Antenatal screening. To prevent vertical transmission, current guidelines dictate that vaginal and rectal swabs must be collected from all pregnant women at 35 to 37 weeks of gestation. Screening at this window is crucial for identifying maternal carriers who require intrapartum prophylaxis. Treatment. When it comes to treating Streptococcus agalactiae, the first-line therapy is penicillin G or ampicillin. However, for serious life-threatening invasive infections like neonatal meningitis or neonatal sepsis, we run a synergistic combination. We administer a cell wall active agent, either ampicillin or penicillin, plus an aminoglycoside, gentamicin. The cell wall active penicillin alters the peptidoglycan synthesis, damaging the cell wall and allowing the gentamicin to easily penetrate the bacterial cytoplasm to reach its ribosomal target. Finally, for prevention, we use intrapartum antibiotic prophylaxis, or IAP. If a mother screens positive for GBS colonization at 35 to 37 weeks, we administer intravenous penicillin during delivery to prevent vertical transmission to the baby. This single intervention has drastically reduced the incidence of early-onset neonatal disease. The resistance profile. The resistance profile. GBS has a very characteristic and highly predictable resistance pattern. First, S. agalactiae possesses intrinsic resistance to bacitracin. This is not an acquired resistance. GBS lacks the target pathway, making bacitracin resistance an excellent diagnostic marker to differentiate GBS from bacitracin-sensitive S. pyogenes. Second, when it comes to penicillins, GBS remains consistently and beautifully susceptible to penicillin. Unlike Staphylococcus or other streptococci, there is no widespread penicillin resistance reported in GBS. Penicillin G remains your unchallenged drug of choice. High-yield board-style MCQs. High-yield board-style MCQs. Let's test your knowledge and lock in these points for your exams. Question 1. A 4-day-old male infant born at 34 weeks of gestation presents with grunting, tachypnea, and temperature instability. The mother had a prolonged rupture of membranes lasting 28 hours. A blood culture grows gram-positive, catalase-negative, oval-shaped cocci in pairs. Which of the following biochemical profiles is most consistent with the causative organism? Is it A. Bacitracin-sensitive, CAMP-negative, bile-soluble, B. Bacitracin-resistant, CAMP-positive, bile-insoluble, C. Bacitracin-sensitive, CAMP-positive, bile-insoluble, D. Bacitracin-resistant, CAMP-negative, bile-soluble? Take a moment to think. The correct answer is B. Bacitracin-resistant, CAMP-positive, bile-insoluble. Here's the clinical rationale. This baby is presenting with classic early-onset GBS sepsis, which is vertically transmitted and strongly linked to prematurity and prolonged rupture of membranes. Biochemically, GBS is catalase-negative, bacitracin-resistant, CAMP-positive, and bile-insoluble. Option A and D mention bile solubility, which is a characteristic of Streptococcus pneumoniae. Option C mentions bacitracin sensitivity, which is a key marker for Streptococcus pyogenes. Question 2. A 14-day-old female infant is admitted with high fever, bulging fontanelle, and seizures. Cerebrospinal fluid analysis confirms pyogenic meningitis, and cultures grow Streptococcus agalactiae. Which of the following parameters is most accurate regarding this infant's condition? Is it A. The disease is classified as early onset and was vertically acquired during delivery. B. The infection is strongly associated with recent maternal obstetric complications. C. This late-onset presentation is most commonly associated with capsular serotype 3. D. The disease is typically non-invasive and can be managed with oral amoxicillin. The correct answer is C. This late-onset presentation is most commonly associated with capsular serotype 3. Let's break down the science. GBS disease presenting between 7 and 90 days of life is classified as late-onset disease, which is horizontally acquired from maternal, nursing, or environmental contact. Unlike early-onset disease, it is not associated with obstetric complications. The most common clinical manifestation of late-onset GBS is meningitis, and it is predominantly caused by capsular serotype 3. Since it is a serious invasive infection, it requires parenteral penicillin ampicillin combined with gentamicin, making oral amoxicillin completely incorrect. Question 3. An obstetrician is reviewing prenatal screening guidelines to prevent neonatal bloodstream infections. To optimize clinical outcomes, at what gestational age should screening for maternal anogenital colonization of group B Streptococcus be performed? And what is the preferred management for positive carriers? Is it A. 24 to 28 weeks, oral erythromycin daily until delivery? B. 35 to 37 weeks, intravenous penicillin prophylaxis during labor? C. 35 to 37 weeks, immediate elective cesarean section? D. 12 to 14 weeks. Intramuscular benzathine penicillin single dose. The correct answer is B. 35 to 37 weeks, intravenous penicillin prophylaxis during labor.